Hi, my name is Laura, and welcome to my audio version of the Family Medicine Pulmonology EOR Study Guide. The rest of the family medicine topics can be found on my channel, but I'll link them below as well. This review is going to follow the PAEA Pulmonology portion of the Family Medicine End of Rotation exam topic list, and I'll timestamp all the topics below in case you'd like to skip around. Let's kick off this video with asthma. Asthma is a reversible obstructive lung disease characterized by airway hyperreactivity, bronchoconstriction, and inflammation. Airway hyperreactivity is most often stimulated by allergen triggers like pollen, dust, or smoke, and associated with increased IgE. But it can also be stimulated by non-allergic triggers like infection, exercise, or certain medications like beta blockers and aspirin. Once the airway is triggered, bronchoconstriction begins. The patient will develop signs of airway narrowing, bronchial wall edema, thick mucus secretion, and air trapping. This results in decreased expiratory airflow and increased airway resistance, so the patient has to work a lot harder to breathe. Inflammation occurs too, due to immune cell infiltration and inflammatory cytokines, and histamine is released from mast cells. Patients will present with a triad of dyspnea, wheezing, and cough, especially at night. Other symptoms include chest tightness, prolonged expiration, wheezing, tachypnea and tachycardia, hyperresonance to percussion with decreased breath sounds, and use of accessory muscles. In severe asthma or status asthmaticus, the patient might present with 2 to 3 word dyspnea, or the inability to speak in full sentences, altered mental status, pulsus paradoxus, which is a decrease in systolic BP with inspiration, cyanosis, tripoding, or silent chest, which indicates no air exchange. Gold standard diagnosis of asthma is done with pulmonary function testing, also called PFT, which shows reduced FEV1 and FEV1 to FVC ratio. But what does that mean? Let's do a super quick review on lung terminology. Forced vital capacity, FVC, is the maximum volume of air you can forcibly exhale after fully inhaling. So, if you take a breath in, but fill up your lungs as much as you possibly can, and then exhale as much as you can force out of your lungs, the total amount you exhale is forced vital capacity, FVC. Now, if you do the exact same thing and force that air out as fast as you can, the air that you exhale in the first second, that's forced expiratory volume in 1 second, also called FEV1. So in asthma, which is an obstructive disorder, it's hard to get air out. So FEV1 will be decreased. Makes sense. And since FEV1 is the fraction of FVC that gets exhaled in 1 second, then the ratio of FEV1 to FVC will also be decreased in asthma. If pulmonary function testing is not diagnostic, there are a few other tests that can be done, like the methacholine challenge test. Methacholine is a cholinergic receptor agonist. It directly acts on muscarinic receptors, which are a main type of cholinergic receptor. So we have these muscarinic cholinergic receptors in various locations throughout the body, but the ones in the lungs are responsible for bronchoconstriction. So ordinarily, we wouldn't want to induce these in asthma. In fact, some asthma meds are muscarinic antagonists, but it's a useful method of diagnosis. So in a methacholine challenge test, the patient is given a nebulizer of methacholine, and then their FEV1 is measured. In an asthmatic, their FEV1 will be decreased by 20% or more. A bronchodilator challenge test can also be done. If giving a bronchodilator increases their FEV1 by 12% or more, then asthma is confirmed. Alternatively, an exercise challenge test can be done, which is exactly what it sounds like. And in asthmatics, their FEV1 will decrease by 15% or more. So now let's talk about acute asthma exacerbation. The best and most objective way to assess severity or response to treatment in an acute asthma attack is by peak expiratory flow rate. That is the maximum flow rate during a forceful exhalation, starting from a full inspiration. Pulse oximetry should also be monitored, and preferably we want it above 94%. A pulse ox of less than 90% is indicative of respiratory distress. Arterial blood gas, or ABG, is also used to assess hypoxia and hypercapnia. In an asthma attack, patients are breathing quickly, breathing off all of that carbon dioxide, so CO2 is going to be lower. In fact, if CO2 starts to increase in these patients, this can actually indicate impending respiratory failure. Treatment in an acute asthma attack begins with oxygen, and then a short-acting beta-2 agonist. A short-acting beta agonist is also referred to as a SABA, and this is typically albuterol in the form of a nebulizer or rescue inhaler. Albuterol acts as a bronchodilator, decreases bronchospasm, increases ciliary movement, and decreases airway edema. And it's often paired with ipratropium in a nebulizer and referred to as a duo-neb. Ipratropium is an anticholinergic that works as an antagonist at muscarinic receptors in the lungs, causing bronchodilation and inhibiting secretions. It's commonly referred to as a short-acting muscarinic antagonist, or SAMA. And this duo-neb of albuterol and ipratropium is commonly the first drug therapy given in an asthma attack. Then it's typically followed by corticosteroids, like prednisone or methylprednisolone, which works as an anti-inflammatory agent. And most asthma exacerbations should be discharged with a short 3 to 5 day course of oral corticosteroids. In severe attacks, epinephrine or magnesium can be considered. Now let's take a step back. How do we classify and treat asthma so that we can try to prevent these acute attacks? Asthma is classified into intermittent, mild persistent, moderate persistent, and severe persistent categories, based on the patient's symptom frequency and FEV1 measurement. Intermittent asthma is defined by symptoms that occur less than 2 days per week and less than 2 nights per month, with an FEV1 greater than 80%. Mild persistent asthma is defined by symptoms more than 2 days per week, but not every day, more than 2 nights per month, and an FEV1 still greater than 80%. Moderate persistent asthma is defined by daily symptoms and symptoms more than 1 night per week, with an FEV1 of 60 to 80%. And severe persistent asthma is defined by continual daytime symptoms and frequent nighttime symptoms, with an FEV1 less than 60%. Treatment of asthma is based off of these classifications. For intermittent asthma, treat with a short-acting beta-2 agonist as needed. This short-acting beta agonist is the SABA, and it's typically an albuterol rescue inhaler that the patient can take when symptoms occur or to prevent symptoms, like before exercise or exposure to allergens. Treatment for asthma between the different classifications is also additive, so every category asthma patient gets a SABA, the albuterol rescue inhaler. For mild persistent asthma, they get the SABA plus low-dose inhaled corticosteroids, also referred to as ICS, inhaled corticosteroids. For moderate persistent asthma, they get the SABA, and then you have a choice. You can either increase the low-dose ICS to medium-dose ICS, or you can do the low-dose ICS with a long-acting beta agonist, referred to as a LABA. For severe persistent, they get the SABA plus medium-dose ICS and a long-acting beta agonist, LABA. Also consider adding theophylline or a leukotriene receptor antagonist. If symptoms persist after this, we can increase the inhaled corticosteroids to high dose or add oral corticosteroids. The next topic is chronic obstructive pulmonary disease, or COPD. This is another obstructive airway disorder, but unlike asthma, COPD is progressive and largely irreversible. COPD is an umbrella term that covers both emphysema and chronic bronchitis. Typically, these coexist, but one is usually more dominant. There are two main risk factors for COPD. Cigarette smoking or cigarette smoke exposure is the number one risk factor and causes 90% of the disease. It's associated with centrilobular emphysema. Alpha-1 antitrypsin deficiency is the other risk factor. This is a genetic disease associated with COPD in patients younger than 40, as well as panlobular emphysema. So let's just connect the pathophysiology between cigarette smoking and alpha-1 antitrypsin deficiency. The enzyme alpha-1 antitrypsin is protective for the elastin in the lungs. It inhibits elastase. Without enough of it, elastase can more easily break down the elastin, causing lung tissue damage. This is what happens in alpha-1 antitrypsin deficiency. And cigarette smoking causes a decrease in this enzyme, as well as an increase in elastase production. So don't smoke. Okay, so COPD is divided into emphysema and chronic bronchitis. Emphysema is characterized by abnormal permanent enlargement of the terminal air spaces. Like we said, cigarette smoking causes chronic inflammation and alveolar damage, as well as that decreased alpha-1 antitrypsin. So elastin in the lungs gets damaged. This leads to a loss of elastic recoil and increased lung compliance. So the airways are more prone to collapse and exhalation becomes an active process requiring more effort. It's hard to get air out for these patients. Emphysema patients present with dyspnea as the most common symptom, as well as accessory muscle usage, tachypnea, and prolonged expiration. Due to the hyperinflation, they will have hyperresonance to percussion, decreased breath sounds, and decreased tactile fremitus. These patients are often thin with barrel-shaped chest with increased AP diameter and purse-lipped breathing. So emphysema patients can be remembered as pink puffers due to their chronic hyperventilation. Unlike emphysema, which typically has a steady decline, chronic bronchitis is usually episodic. It's defined by a productive cough occurring more than 3 months in 2 consecutive years. Chronic airway inflammation leads to hypersecretion of mucus, airway narrowing and resistance, and destruction of the mucociliary escalator. This is the term for the mucus and cilia that beat upwards in our respiratory tract and allow trapped particles to be propelled up and out of the lungs. It's a major defense mechanism against infection, so without it, these patients become very prone to microbial infections. The hallmark of chronic bronchitis is the productive cough, as well as prolonged expiration, because it's hard for them to get air out. They'll have rales, rhonchi, and/or wheezing, and might have signs of cor pulmonale. They're often hypoxemic and cyanotic as well, so chronic bronchitis patients can be remembered as blue bloaters. Gold standard diagnosis of COPD is pulmonary function testing. But before we get into that, let's review lung volume terminology. First, tidal volume is the amount of air that moves in or out of the lungs with a normal breath. Then there's inspiratory and expiratory reserve volumes. After you inhale normally in a regular breath, if you were to continue to inhale and fill up all that extra space in your lungs, that extra is inspiratory reserve volume. Okay, now if you were to take a normal breath and exhale normally, then continue to forcibly exhale all the rest of that air you can out of your lungs, all the rest of that air you get out is expiratory reserve volume. But you can't possibly exhale all of the air out because that's just not possible. So what's left over after that forceful exhale is residual volume. Residual volume inspiratory and expiratory reserve volumes and tidal volume together make up total lung capacity. Okay, there are just a few more terms to know. Forced vital capacity, or FVC, is the volume of air exhaled from a maximally inflated lung as a patient forces the air out. And forced expiratory volume in 1 second, commonly referred to as FEV1, is the volume of air exhaled in the first second of forced expiration. All right, now on to pulmonary function testing. Gold standard diagnosis of COPD is pulmonary function testing, also called PFTs or spirometry. This quantifies airflow and measures a lot of the lung volumes we just talked about, specifically FEV1 and forced vital capacity, or FVC. The measurement we care about is the FEV1 to FVC ratio. An FEV1 to FVC ratio less than 70%, or 0.7, indicates obstructive pulmonary disease. You'll also see FEV1 and FVC are both decreased as well, but just remember that FEV1 to FVC ratio will be low. And if the patient is emphysema dominant, pink puffers with that barrel chest, you might also see some increased lung volumes due to hyperinflation, specifically increased total lung capacity and residual volume. Lastly, CT scan isn't particularly helpful in diagnosing COPD, but it might show hyperinflation with a flat diaphragm and increased AP diameter. The single most important intervention for COPD is smoking cessation. Help these patients kick the habit. Preventing infection is also important, since infections like flu and pneumonia cause exacerbations. So keep these patients up to date on their flu shots and the pneumococcal vaccine. Pulmonary rehab is another intervention to consider, and it often improves dyspnea and exercise tolerance. As far as pharmacologic treatment goes, the main categories of meds used include bronchodilators, corticosteroids, and oxygen. Let's go through these meds first, and then we'll go through when to prescribe them. Bronchodilators are the treatment of choice in stable COPDers with respiratory symptoms. There are 3 main types of bronchodilators that are used: anticholinergics, beta-2 agonists, and theophylline. Anticholinergics block acetylcholine-mediated bronchoconstriction, resulting in bronchodilation. The common long-acting anticholinergic is tiotropium or Spiriva, and the common short-acting one is ipratropium or Atrovent. Side effects are the typical anticholinergic effects like dry mouth, blurred vision, and urinary retention. Anticholinergics are contraindicated in those with BPH and glaucoma. Beta-2 agonists are the next type of bronchodilator. They activate the beta-2 receptors in the lungs, remember beta-2, 2 lungs, resulting in bronchodilation. The most common short-acting beta agonist is albuterol, and the common long-acting one is salmeterol, but there are a number of others. Side effects are typically minimal, but can cause tachycardia, muscle tremors, and CNS stimulation. Beta-2 agonists are contraindicated in severe coronary artery disease. Theophylline is the last of the bronchodilators, but it's only used in refractory cases. It has a narrow therapeutic window and can cause nausea, palpitations, arrhythmias, or seizures at toxic levels. As COPD progresses, patients might need corticosteroids added to their regimen. Inhaled corticosteroids are not considered monotherapy, but can be added to long-acting bronchodilators. Side effects of steroids include osteoporosis, thrush, increased incidence of infections, and hyperglycemia. As COPD continues to progress, oxygen might be added to the regimen as well. Oxygen is the only medical therapy proven to decrease mortality because it reduces hypoxia-mediated pulmonary vasoconstriction. This decreases pulmonary hypertension and thus cor pulmonale. Oxygen is indicated if there is cor pulmonale, if oxygen saturation is less than 88%, or if PaO2 is less than 55 millimeters of mercury. So how do we know when to prescribe each of these medications? Treatment is guided by the stage of COPD. There are 4 stages based on the patient's FEV1 value. Remember, all stages have an FEV1 to FVC ratio less than 70%, but their FEV1 values will differ. So stage 1 is mild with an FEV1 greater than 80%. Stage 2 is moderate with an FEV1 of 50 to 80%. Stage 3 is severe with an FEV1 of 30 to 50%. And stage 4 is very severe with an FEV1 less than 30%, cor pulmonale, respiratory failure, or heart failure. Treatment of COPD is additive, so as the disease progresses, we're adding more meds to the regimen. Stage 1, or mild COPD, gets a short-acting bronchodilator, typically albuterol. Stage 2, or moderate COPD, gets albuterol plus a long-acting bronchodilator like tiotropium or salmeterol. Stage 3, or severe COPD, gets albuterol plus a long-acting bronchodilator plus an inhaled corticosteroid. If symptoms still aren't controlled, another long-acting agent can be added, either an anticholinergic or a beta agonist, whichever you didn't add before. And stage 4, or very severe COPD, gets all of these meds plus oxygen. A final treatment option is surgery, either lung reduction or transplantation. In lung reduction surgery, damaged lung is removed, allowing the remaining lung to expand and function more efficiently. Lastly, in the case of acute bacterial exacerbations of COPD, consider oral steroids and antibiotics, specifically azithromycin. And that wraps up the COPD topic. The next topic is bronchitis, as in acute bronchitis. This is an inflammation of the bronchi and trachea that typically follows an upper respiratory infection. It's generally caused by a virus, most often adenovirus, but other viruses and some bacteria can be the culprit too. Acute bronchitis is characterized by a productive cough that usually lasts 1 to 3 weeks. Other symptoms include chest discomfort, shortness of breath, and fever. Diagnosis is usually clinical, and a chest x-ray isn't needed unless it's to rule out pneumonia, since these conditions present similarly. But in acute bronchitis, chest x-ray is usually normal or nonspecific. Treatment of acute bronchitis is usually symptomatic. Fluids, rest, NSAIDs or Tylenol, bronchodilators like albuterol, and in adults, antitussives might be used. Antibiotics are not usually indicated in acute bronchitis because the cause is normally viral, and because there's no statistical benefit in healthy patients. In patients who are elderly, immunocompromised, have chronic respiratory disease, or are not responsive to conservative treatments, then antibiotics can be considered. The next topic is pneumonia, which is an infection of one or both lungs that's caused by a bacteria, virus, or fungus. It's often classified by setting, like community-acquired, hospital-acquired, immunocompromised, and aspiration. Community-acquired pneumonia is when the illness is acquired outside of the hospital setting, and the patient is not a resident of a long-term care facility. Or it's if the patient develops pneumonia within 48 hours of hospital admission, because then it was likely acquired before they were admitted. Hospital-acquired pneumonia is when illness occurs more than 48 hours after hospital admission. And this distinction is important because the causative pathogens are different. For example, hospital-acquired pneumonia is often caused by Pseudomonas or MRSA. So community-acquired pneumonia is classified as typical or atypical, based on clinical presentation. Typical pneumonia presents with fever, productive cough, pleuritic chest pain, tachycardia, and tachypnea. Physical exam shows signs of consolidation, like increased tactile fremitus, agophony, dullness to percussion, and inspiratory crackles. And the chest x-ray shows lobar consolidations. Typical pneumonia is caused by strep pneumonia, which is most common, H. influenza, Klebsiella, and Staph aureus. In contrast, atypical pneumonia is a more mild illness. It's also called walking pneumonia and presents with a low-grade fever, a dry, non-productive cough, and other non-pulmonary symptoms like malaise, myalgias, headache, nausea, and diarrhea. Physical exam is often normal too, and chest x-ray shows diffuse, patchy, interstitial infiltrates. Atypical pneumonia is most often caused by Mycoplasma pneumoniae, as well as Chlamydophila pneumoniae, Legionella, and viral pathogens. Now let's divide this topic up by pathogen, starting with bacteria. First is Streptococcus pneumonia. This is the most common cause of community-acquired pneumonia. It's gram-positive cocci, and it causes that rust-colored, blood-tinged sputum, as well as rigors. Strep pneumonia is also common in patients with splenectomy. Next is Haemophilus influenza. This is the second most common cause of community-acquired pneumonia, and it's associated with underlying pulmonary disease, especially COPD and smokers. H. flu is a gram-negative rod. Next is Klebsiella pneumonia, another common cause of community-acquired pneumonia. It's a gram-negative rod and can cause currant jelly sputum. You can remember Klebsiella with the 3 A's. It's associated with alcoholics, aspiration, and abscess. Abscess formation can result in lung cavitation, which shows up on chest x-ray as cavitary lesions, often of the upper right lobe, and it causes severe illness in alcoholics, chronically ill or debilitated patients, and those who aspirate. Next is Staphylococcus aureus, which is another cause of community-acquired pneumonia. This one is typically seen after a viral illness like the flu. It's also associated with the immunocompromised, elderly, and IV drug users. Staph aureus are gram-positive cocci in clusters that cause salmon-colored sputum and often bilateral pneumonia. When it's methicillin-resistant, it's called MRSA, or methicillin-resistant Staph aureus, and this is a big concern in hospital-acquired pneumonia. When MRSA is suspected, additional antibiotics, like vancomycin, are added to the treatment regimen. Next is Mycoplasma pneumoniae. This is the most common cause of atypical pneumonia, or walking pneumonia, and the most common cause in young adults. It's associated with young, otherwise healthy individuals, especially those in close quarters, like college dorms or the military. Symptoms that are more specific to mycoplasma are pharyngitis, a macular rash, and ear pain due to bullous myringitis, which is an infection of the tympanic membrane. Mycoplasma is also unique in that it lacks a cell wall, so it doesn't respond to beta-lactams, and it can't be stained by gram staining. PCR can be used to detect it, as well as serum cold agglutinins, but the diagnosis is usually just clinical. Next is chlamydia pneumonia, which is another cause of atypical pneumonia. It causes hoarseness, a sore throat, sinusitis, and is more common in younger patients, especially college-aged. Next is Legionella pneumophila, also called Legionnaire's disease. This one is unique because there is no person-to-person transmission. It's transmitted through contaminated water or aerosols from ventilation systems, so it's associated with recent travel, especially cruise ships or hotel stays. In addition to atypical pneumonia symptoms, Legionella causes nausea, vomiting, diarrhea, hyponatremia, increased LFTs, a high fever, bradycardia relative to the high fever, and sometimes confusion. Diagnosis is most commonly made with a rapid urine antigen test, and levofloxacin or azithromycin should be added to the treatment regimen if Legionella is suspected. Next are anaerobes as a whole. These are associated with aspiration pneumonia and poor dentition. Anaerobes can cause foul-smelling sputum, lung abscess, and empyema. And treatment is a little different from community or hospital-acquired pneumonia, which we'll go over at the end. For aspiration pneumonia, treatment includes clindamycin or metronidazole or augmentin to cover for the anaerobes. The last bacteria is Pseudomonas, which is a common cause of hospital-acquired and ventilator-acquired pneumonia. It's also associated with cystic fibrosis, bronchiectasis, and immunocompromised individuals that are HIV positive, neutropenic, or status post-transplant. Pseudomonas is a gram-negative rod and should be treated with an anti-pseudomonal beta-lactam and anti-pseudomonal aminoglycoside or fluoroquinolone. So that covers the bacterial pneumonias. The virus list is quite a bit shorter. The most common cause of viral pneumonia in adults is influenza. Pretty easy to remember. The most common causes in children are RSV and parainfluenza. And cytomegalovirus, or CMV, is associated with viral pneumonia in organ transplant patients and those with AIDS. Most viral pneumonia is treated supportively. And look, we're already done with viruses. Now for fungus. Fungal causes of pneumonia are predominantly a concern in immunocompromised patients with HIV. First is Pneumocystis jirovecii, which is the most common opportunistic infection in HIV, especially with CD4 counts below 200. But it doesn't cause disease in immunocompetent patients. So, in HIV patients, symptoms include fever, dyspnea, non-productive cough, and oxygen desaturation with exertion. Diagnosis is done with chest X-ray, which shows diffuse bilateral interstitial infiltrates, and a definitive diagnosis can be made with a bronchoalveolar lavage or sputum specimen. Treatment is Bactrim, and prednisone can be added for hypoxia. And all HIV patients with CD4 counts below 200 should get prophylactic Bactrim to prevent this infection. Next is Histoplasma capsulatum, which is a common opportunistic infection in HIV patients with a CD4 count less than 150. It's associated with soil contaminated with bird or bat droppings, particularly in the Mississippi and Ohio River valleys. You can remember this by hiss on the miss. It's also seen in spelunkers, those who explore caves, and excavators in those areas. Most cases of histoplasmosis are asymptomatic, but flu-like symptoms can occur. In immunocompromised patients, however, it can disseminate, causing fever, hepatosplenomegaly, and multi-organ failure. In disseminated disease, diagnosis is made with a positive blood culture. Sputum cultures and PCR can also be done. Treatment of mild to moderate disease is itraconazole, and amphotericin B is used in severe disease. And all HIV patients with CD4 counts below 150 who live in affected regions should get prophylactic itraconazole to prevent this infection. Next is coccidioides, which is another common opportunistic infection in HIV patients. It's found in soil of southwestern desert regions of the U.S. It generally causes a mild flu-like illness, but can also cause valley fever, which includes arthralgias, pain and swelling of the knees and ankles, erythema nodosum, erythema multiforme, and a maculopapular rash. In immunocompromised individuals, it can cause disseminated disease, and that most often causes meningitis, but can affect any organ, especially the lungs. A chest X-ray will show cavitations, miliary pneumonia, abscesses, and nodules. And the initial diagnostic test is typically IgM and IgG antibodies, but a definitive diagnosis is by cultures. Most cases are mild and don't require any treatment. Moderate cases can be treated with fluconazole or itraconazole, and severe disease is treated with amphotericin B. Next is Cryptococcus, which is a common opportunistic infection in HIV patients with a CD4 count less than 100. This is an encapsulated budding yeast that's transmitted through inhalation of bird or pigeon droppings. Cryptococcus can cause meningitis or pneumonia, and the pneumonia presents with cough, dyspnea, and skin lesions might be present if it's disseminated. Treatment is amphotericin B plus flucytosine plus fluconazole. And HIV patients with CD4 counts below 100 sometimes get prophylactic fluconazole, but routine prophylaxis is not always indicated. And that wraps up the fungal pneumonias. Diagnosis of pneumonia starts with a chest x-ray, but it might include a CT scan as well. Remember, chest x-ray of typical pneumonia has lobar consolidations, and atypical pneumonia has diffuse patchy infiltrates. If there's abscess formation on imaging, it's more likely to be caused by Staph aureus, Klebsiella, or anaerobes. And upper lobe cavitations or bulging fissure is more likely Klebsiella from aspiration. In fact, upper lobe pneumonia in general is associated with aspiration. For patients that get admitted, blood cultures can be done, as well as a sputum culture, but the usefulness of that is debated. Gross sputum, however, can help identify the pathogen. For instance, rust-colored sputum is likely strep pneumonia. Currant jelly sputum tends to be Klebsiella. Green sputum is seen in H. flu or Pseudomonas, and foul-smelling sputum tends to be anaerobes. Urinary antigen testing is used for Legionella and Staph aureus, and nasal swabs can be done to rule out or in certain viruses. Once diagnosis is made, then we have to decide whether or not to admit the patient to the hospital. This is typically a clinical judgment, but there are two scores that can help with that decision: the Pneumonia Severity Index and the CURB-65. Also consider hospitalizing patients with multi-lobar pneumonia, neutropenia, and complicated comorbidities. We already discussed viral and fungal treatment, so now we're going to focus on antibiotic management for bacterial pneumonia. Community-acquired outpatient treatment is a macrolide or doxycycline. Community-acquired inpatient treatment is a beta-lactam, like ceftriaxone, plus a macrolide. If they're in the ICU, they can still get the beta-lactam plus macrolide, or they can get the beta-lactam plus a broad-spectrum fluoroquinolone. Now, for hospital-acquired pneumonia, treatment is an anti-pseudomonal beta-lactam, like piperacillin tazobactam, plus an anti-pseudomonal aminoglycoside or fluoroquinolone. If MRSA is suspected, add vancomycin or linezolid. If Legionella is suspected, add levofloxacin or azithromycin. And if pneumocystis pneumonia is suspected, add Bactrim. Lastly, there are two pneumococcal vaccines to know. The Prevnar vaccine is given as a 4-dose series during childhood, and the Pneumovax vaccine is given in adults age 65 and older. The next topic is tuberculosis. Tuberculosis is caused by infection with Mycobacterium tuberculosis, which leads to granuloma formation in the lungs. Mycobacteria are rod-shaped aerobes with a particularly waxy cell wall due to mycolic acid production. Because of this waxy cell wall, they are considered acid-fast, since they can hold on to dye despite being exposed to alcohol, which also means they can't be gram-stained, since that uses alcohol. So an acid-fast stain is used to detect Mycobacterium, but we'll cover this when we go over diagnosis. Risk factors for tuberculosis, also referred to as TB, include HIV, other immunodeficiencies, immigration from an endemic area, immunosuppression, malnutrition, and close proximity to TB patients, such as those in healthcare, prisons, the homeless, etc. This is because the pathogen is transmitted through airborne droplets. About 2 billion people worldwide are infected with TB, but about 90 to 95% of them are asymptomatic or even undiagnosed because their immune system is able to contain it, so the bacteria lies dormant. However, if their immune system gets knocked down, like in the case of AIDS or just the aging process in general, then tuberculosis can reactivate and cause illness. So there are essentially 3 different classifications of tuberculosis infection: primary TB, chronic or latent TB, and secondary or reactivation TB. Let's go through each of these. In primary tuberculosis, the patient develops symptoms shortly after being exposed. Primary TB affects the lower and middle lobes of the lungs, but it's usually asymptomatic or presents with mild flu-like symptoms. And without any intervention, in about 3 weeks, it'll progress to latent TB. What happens is that the immune cells surround the site of TB infection in the lungs and try to wall off that bacteria, creating a granuloma. The tissue inside the granuloma dies, or necroses, called caseating necrosis, and is known as a Gone focus. The characteristic Gone complex of TB consists of the Gone focus and its associated hilar lymph node. The encapsulated tissue then typically undergoes fibrosis and calcification, which can be seen on X-ray, and the calcified Gone complex is called a Reinke complex. In some patients, this whole process of walling off the bacteria actually kills the mycobacteria and resolves the tuberculosis. But in other patients, the bacteria remains viable but dormant. This is called latent TB, which is always asymptomatic and not contagious. However, when the immune system is compromised, the Gone focus reactivates, causing reactivation or secondary TB. The secondary infection spreads to the upper lobes of the lung, where there's higher oxygen content. Memory T cells release cytokines to fight the infection, but this causes more areas of caseating necrosis. And this time around, these areas of tissue necrosis tend to cavitate, forming cavitary lesions that can allow the bacteria to spread through the lymphatic or vascular systems to the rest of the body. When TB spreads outside of the lungs, it's termed miliary TB. Now let's talk about symptoms. When tuberculosis is active, pulmonary TB presents with chronic productive cough, pleuritic chest pain, fever, chills, night sweats, weight loss, and sometimes hemoptysis. A physical exam will show signs of consolidation. Extrapulmonary TB, when the bacteria has spread through the rest of the body, can affect any organ. Common extrapulmonary symptoms include meningitis, when the meninges are affected, Pott's disease, when the lumbar vertebrae are affected, Addison's disease, when the adrenal glands are affected, hepatitis in the liver, lymphadenitis in the neck, and pericarditis. Tuberculosis can be screened for with a PPD test, which stands for Purified Protein Derivative. As a healthcare student, you probably had to get one of these before going out on clinical rotations. It contains tuberculin, which is a component of the tuberculosis bacteria. They inject it intradermally on the forearm, and then it has to be read or assessed in the next 48 to 72 hours. If you've been exposed to TB previously, the immune system causes a little local induration. When assessing the results of this test, only the induration is being measured, not the erythema. Redness is not a positive test result. So in a healthy individual, they're considered positive and we need to treat them if the induration is 15 millimeters or greater. We treat patients with a 10 millimeter or greater induration if they are recent immigrants from endemic areas, IV drug users, residents or employees of high-risk settings like prisons or hospitals, or children under 5 years old who are exposed to adults in any of these categories. And in those with a 5 millimeter or greater induration, we treat them if they are HIV positive, had a recent TB contact, have chest X-ray findings consistent with prior TB, or are otherwise immunosuppressed. An alternative to the PPD test is the interferon gamma release assay, or IGRA. This one is a blood test, and it's more specific to tuberculosis. It's useful because a lot of children around the world receive the BCG vaccine, which protects against tuberculosis, but it can also cause a false positive PPD skin test. So screening for these individuals is done with the IGRA blood test. So that was TB screening. Now on to diagnosis. If you suspect TB in a symptomatic patient, collect either sputum samples or samples from bronchoalveolar lavage, which go to the lab for an acid-fast smear, staining, and culture. The gold standard diagnosis is acid-fast bacilli, or AFB, cultures, and TB can be ruled out after 3 negative smears. Chest x-rays can also be used to rule out active TB, such as in the case of a newly positive PPD skin test. Tuberculosis has some common x-ray characteristics. For example, primary TB presents as consolidation in the middle or lower lobes. Reactivation TB presents as fibrocavitary disease in the upper lobes. Miliary TB presents as small millet seed-like nodular lesions. TB pleurisy occurs when tuberculosis infection causes a pleural effusion. And then, of course, granulomas, Gone complex, and Ranke's complex are all signs of TB. Treatment of active TB can be remembered with the acronym RIPE, R-I-P-E, and this stands for rifampin, isoniazid, pyrazinamide, and ethambutol. And there are a few things to know about each of these drugs. Rifampin causes red-colored bodily secretions like tears and urine. Isoniazid can cause peripheral neuropathy and sideroblastic anemia, which can be prevented by giving vitamin B6. It can also cause hepatitis and drug-induced lupus. Pyrazinamide can cause hepatitis and hyperuricemia. And ethambutol can cause optic neuritis and peripheral neuropathy. Some ways that I remember this are that rifampin starts with R, and so does red. Rifampin causes red-colored secretions. And ethambutol starts with an E, and so does I. Ethambutol causes optic neuritis. Additionally, sometimes ethambutol is switched out for streptomycin, and possible side effects to know for streptomycin are ototoxicity and nephrotoxicity. So now on to prescribing these medications. When treating active TB, patients get the RIPE regimen for 6 months total. So we say that they get 4 drugs for 2 months and then 2 drugs for 4 months. This basically means that they get all 4 medications, rifampin, isoniazid, pyrazinamide, and ethambutol, for the first 2 months. Then after that, they typically continue just rifampin and isoniazid for another 4 months. In patients with latent TB, meaning they are asymptomatic but with a positive PPD skin test and no evidence of active infection on imaging, treatment reduces the risk of reactivation TB in the future. Latent TB treatment is isoniazid for 9 months, and normally vitamin B6 is added to that too. One last thing. There is growing concern about multi-drug resistant and extremely drug resistant strains of TB that are particularly difficult to treat. We're not going to go into that here, but just be aware that it exists. The next topic is lung cancer, which is the most common cause of cancer death. The most common cause is cigarette smoking, including secondhand smoke. The second most common cause of lung cancer is asbestos. Lung cancer can be asymptomatic, or it can present with cough, hemoptysis, dyspnea, anorexia, and weight loss. Lung cancer can be divided into small cell carcinoma, and then all of the others, referred to as non-small cell carcinoma. Non-small cell carcinoma accounts for the majority of lung cancer and includes 4 subtypes: adenocarcinoma, squamous cell carcinoma, large cell carcinoma, and carcinoid tumor. The most common type, about 40% of all lung cancers, are adenocarcinoma. These are peripherally located, presenting with a peripheral mass, and they arise from the mucus glands. They tend to metastasize to distant areas and grow quickly. Squamous cell carcinoma is bronchial in origin, so it's centrally located. It can present with hemoptysis and might be able to be picked up on a sputum cytology. Squamous cell carcinoma causes necrosis and cavitary lesions, as well as PANCE tumors at the superior sulcus of the lung. These tumors can cause shoulder pain, atrophy of the arm muscles, and Horner syndrome, which is unilateral facial anhidrosis, no sweating, ptosis, and meiosis. Squamous cell carcinoma causes hypercalcemia too, due to elevated parathyroid hormone-related peptide. Large cell carcinoma, also referred to as anaplastic carcinoma, is a very aggressive cancer with poor prognosis. It's peripherally located and doubles in size very quickly. It's also associated with gynecomastia and galactorrhea. Lastly, carcinoid tumors are much more rare. They're low-grade, slow-growing neuroendocrine tumors with low metastasis. Carcinoid tumors most often occur in the GI tract, but the lungs are the second most common site. They secrete serotonin, ACTH, ADH, and melanocyte-stimulating hormone. Most cases are asymptomatic but might present with wheezing or coughing, SIADH, Cushing syndrome, or obstruction. Carcinoid syndrome can also occur, which is characterized by diarrhea due to the increased serotonin, as well as flushing, tachycardia, bronchoconstriction, and hemodynamic instability due to increased bradykinin and histamine. So that covers the 4 non-small cell carcinomas. Let's move on to small cell, sometimes called oat cell carcinoma. About 15% of all lung cancers are small cell carcinoma. They're centrally located, highly aggressive, and metastasize very early, so most of the time they've already metastasized by the time they're found. They're associated with SIADH, Cushing syndrome, and Lambert-Eaton syndrome. You can remember this by the first letters in the words small cell lung, SCL. S for small is also for SIADH. C for cell is also for Cushing, and L for lung is also for Lambert-Eaton syndrome. The SIADH and Cushing's cause hyponatremia and hypercalcemia, respectively, and Lambert-Eaton syndrome is muscular weakness that improves with continued use. Small cell carcinoma is also associated with superior vena cava syndrome, which is when the superior vena cava is obstructed by a tumor, causing facial and arm edema, dilated anterior chest veins, and JVD. Obstruction can also lead to phrenic nerve palsy, recurrent laryngeal nerve palsy and hoarseness, and Horner syndrome. Before we go on, a trick I use to remember which lung cancers are located centrally versus peripherally is that if they start with an S sound, like squamous cell or small cell, then they are centrally located, which also has an S sound, centrally located. So squamous cell and small cell. The rest are located peripherally. So the initial test for lung cancer is a chest x-ray. Then a CT is used for staging. A biopsy is used for definitive diagnosis and to determine the histologic type. Sputum cytology and bronchoscopy can be used for central lesions, and a transthoracic needle biopsy is used for peripheral lesions. Treatment is broken down into small cell and non-small cell again. In general, the non-small cell carcinomas are treated with surgery. Stage 1 and 2 get surgical resection, and stage 3 gets chemo, then surgery. Stage 4 is mostly palliative. In contrast, the treatment of choice for small cell carcinoma is chemotherapy plus or minus radiation. Small cell cancer is not treated with surgery because it's usually already spread by the time it's found. So small cell gets chemo and non-small cell gets surgery. The next topic is sleep disorders, which is primarily referring to sleep apnea. There are two types of sleep apnea, central and obstructive. In central sleep apnea, a reduced CNS respiratory drive causes reduced respiratory effort during sleep. And in obstructive sleep apnea, a physical airway obstruction disrupts breathing during sleep. Obstructive sleep apnea is the most common type, so this section will focus on that. The strongest risk factor is obesity, but other risk factors include age over 60, and it's more common in males. Sleep apnea presents with snoring, choking during sleep, and daytime sleepiness due to unrestful sleep. Physical exam might show a large neck or a crowded oropharynx. Diagnosis is made by polysomnography, a sleep study, which is positive if there are more than 15 respiratory events per hour. And the mainstay of treatment is CPAP, which stands for continuous positive airway pressure. Sleep apnea patients usually love their CPAP machines and have significantly improved sleep with them. Other management options should include weight loss when appropriate, abstaining from alcohol, and changes in sleep position. And in severe cases, surgical correction might be considered. Treatment of sleep apnea is important because it can eventually lead to complications, including pulmonary hypertension and arrhythmias. And the last topic is tobacco use and dependence. Cigarette smoking is related to a variety of poor health outcomes and reduced lifespan. Tobacco is a major cause of pulmonary, cardiac, and cancer deaths. Nicotine binds to the nicotinic receptors in the nervous system, causing the release of dopamine, acetylcholine, and glutamate. Remember, dopamine is like a reward chemical for the brain, which is part of why it's so addictive. Nicotine also blocks GABA inhibition, increasing GABA. All these effects result in increased blood pressure, heart rate, cardiac contractility, GI tract activity, and decreased muscle tone. And nicotine is metabolized by the liver with a half-life of 1 to 2 hours, which is why it's common for smokers to take smoke breaks about that often. Nicotine withdrawal causes restlessness, anxiety, irritability, sleep disturbances, depression, and, of course, nicotine cravings. So how do we help our patients quit? We can recommend counseling and therapy, but there are also a variety of pharmacological options too. First-line options include varenicline, also called Chantix, bupropion, also called Wellbutrin or Zyban, and nicotine replacement therapy. Chantix typically has the best efficacy, and it works by blocking nicotine receptors, which reduces nicotine activity. Bupropion is an antidepressant that is often combined with nicotine tapering. And tapering therapy can be done using nicotine gum, nasal sprays, transdermal patches, inhalers, or lozenges. And that wraps up the pulmonology portion of the Family Medicine EOR exam study guide. If you're listening to these videos in order, the next section is the gastrointestinal and nutritional section, which I'll post soon. But I'm also uploading some of the other EOR topics concurrently. Lots of content getting uploaded, so stay tuned, subscribe to the channel, and thank you so much for listening. Happy studying, and I'll see you in the next video.